This conference will now be recorded.
Good morning, students.
Morning, ma'am.
Audible, right?
Yes, ma'am.
Okay. So today we will discuss about the treatment of diabetes. In the previous class, what did we see? Or what did we know about diabetes? In the initial classes, we got to know about the introduction and what is it and what is the mechanism or how is it pathophysiology and all in the first class. In the second class, we talked about the complications in general, and now we are discussing about the treatment. In the treatment aspect, we'll discuss it under two classes. One is the tablets or oral hypoglycemic agents, which we are going to use for diabetes, and in the other class, we'll discuss about insulins. Okay. So initially, whenever a patient comes to you, which is the drug you think like you'll be keeping for a patient of diabetes, type 2 diabetes? Any idea? You want to give some answers in the chat box? Yes, metformin. Why is it metformin? Very immediately you answered metformin. It's well-known drug that metformin is one of the agent which is initially used for diabetes, irrespective of the sugar levels or diabetes status. So that is the minimum idea which everyone has. So what we need to know is something beyond that. That beyond that comes in this two classes where you will be discussing more about other types of OHS, when to start it, how to use it and all. And then insulins also, more of how and when this titration is more of with the insulins compared to that of OHS. Okay. Usually OHS are oral hypoglycemic agents or drugs. Okay, the classification goes like that. Sulfonylureas, non-sulfonylureas like meglitinide, biguanides, thiazolidinediones, alpha-glucosidase inhibitors, SGLT2 inhibitors, and PPAR dual agonists, alpha and gamma, incretins, dual agonists as well as alpha agonists, both are gamma agonists, both are there. Incretins, they are the injectable drugs. Not only insulins are injectable, but also some of the oral hypoglycemic agents like incretins are injectable. They are GLP-1 agonists, and the tablet oral form is DPP-4 inhibitors. Okay, this is the broad classification of OHS. I think this you remember from your pharmacology classes, so it will be much easier for you. Coming to sulfonylureas again, they're again divided into first and second generation. First generation tolbutamide chloropropamide, which we are not using nowadays, and the second generation is glibenclamide or glyburide, which is a bit long acting compared to that of glimepiride and glipizide. And the mechanism of action of sulfonylureas. Anyone can tell me the mechanism of sulfonylureas from your pharmacology classes? Do you remember? So, okay, there's nothing but like if at all you see in this case, it is nothing, sulfonylurea is nothing but a potassium channel blocker, or the one which closes the potassium channels. Whenever the potassium channel is closed, what is happening with the potassium inside the cell? Potassium is increasing. Why? Potassium is something present intracellularly, right? Intracellular ion. So when you're blocking its exit, what is it's happening? Potassium levels inside the cell are increasing. When the potassium level is increasing, it is a positively charged ion. So what happens to the membrane? Membrane depolarization occurs. Whenever the depolarization occurs or the positivity increases, that triggers the opening of the calcium channels. When the calcium channels are opened, what happens to the calcium? Calcium enters into the cell. Whenever the calcium is getting into the cell, what is it's doing? It is helping in the coulées of the insulin granules, and it's outpouching or insulin release to the outside of the cell. So that is how this insulin is secreted. I mean, usually, okay. This is the mechanism of sulfonylurea, where they are causing depolarization is occurring, calcium is increasing, and insulin is released because of potassium channel blockade, which is done by sulfonylurea. That is what sulfonylureas are doing. In general, what is the mechanism? Whenever the glucose enters the cell, in the glucose present state or glycemic state in our body, for every individual, when glucose is entering in the cell, ATP increases, and then the potassium, usually the channel closes and membrane depolarization. This is usually happening inside our body in presence of glucose. So in diabetes, where it is a kind of insulin resistant state, insulin is not being utilized properly in the body because of insulin resistance. At that time, we are giving sulfonylureas and increasing the insulin in our body, so at least we can to an extent increase the insulin release and prevent the hyperglycemic state. For that, the mechanism is same as that of which is occurring inside our body, just we are blocking the potassium channels. Okay. Potassium channel, when blocked, they increase insulin release and they decrease glucagon release and increase insulin receptor sensitivity. These three are the mechanisms of action of sulfonylureas. Sulfonylurea is one of the most commonly used drugs, so it is very important for you to remember the mechanism of action of sulfonylurea. And if you come to the dosage, the initial dosage of glyburide is 2.5 mg to 5 mg orally once a day, and you can go up to a maximum of 20 mg per day. But remember, as glyburide or glibenclamide is a long acting, it has more tendency to produce hypoglycemic changes compared to that of glimepiride or glipizide. And coming to the dosage of glipizide, it is initial dose is 5 mg orally, which is taken once a day, 30 minutes before the breakfast, and you can go up to a maximum of 20 mg. But usually we don't go up to 20 mg. Coming to the dosage of tolbutamide, it is usually 1 to 2 grams orally once a day or in divided doses throughout the day, and the maximum dose which you can achieve is like 3 grams per day. And coming to the adverse effects, the most common adverse effect reported because of sulfonylureas are hyperglycemia. Why hyperglycemia? Because it is nothing but the insulin. Insulin is increasing in our body. If at all the insulin is acted in a way like according to its mechanism of action, the hypoglycemia occurs because of increased insulin levels. So it is always, why are we saying specifically hypoglycemia here? Because hypoglycemia is not encountered in case of metformin usually, according to the books. So when metformin is not causing hypoglycemia, whereas sulfonylurea is causing a hypoglycemia. Why do you have to remember it? Because whenever a patient comes to you, he should be taking a combination drug and he presents with hypoglycemia. Then which drug to stop or which drug to decrease the dose? It is the sulfonylurea, because most of the drugs are combination drugs which we give glimepiride plus metformin or glibenclamide plus metformin. So in this case, whenever the patient comes with hypoglycemia, it is because of the sulfonylurea, not because of the metformin. That is what you have to remember. And coming to the other adverse effects, as it is a sulfur drug, it also has a tendency for hypersensitivity reaction. And chlorpropamide causes cholestasis and dilutional hyponatremia and intolerance to alcohol. Okay, so tolbutamide reduces iodine uptake by thyroid. So remember, when you are doing the thyroid isotope scans and all, sulfonylureas are secreted in milk, and so it is contraindicated in lactating mothers. So if at all you are thinking to put a diabetic patient or like a GDM patient or who is pregnant, then you have to go with, you should not go with sulfonylureas. If at all you want to give a sulfonylurea, the better one in pregnancy is glyburide, but usually it is contraindicated in lactation. In pregnancy you can give glyburide, but usually we don't use sulfonylureas. Coming to the next group of drugs, that is non-sulfonylureas. Non-sulfonylureas are also known as medeatonide or diphenylaniline analogs. And the example are rapaglinide and natiglinide. And its mechanism of action is that of is similar to that of sulfonylureas, but they don't have a sulfonylurea moiety. And it has short duration of action and low risk of hypoglycemia. See, here the potassium channel is blocked by sulfonylurea, I told you. Sulfonylurea attaches to this pump in a particular site. Coming to non-sulfonylureas, they also block this potassium channel, but they don't attach to the same site as that of sulfonylureas. So that is how they do differ from each other. And the next difference is that they have a very short duration of action compared to that of sulfonylureas. Adverse effects are rapaglinide can cause hypoglycemia, weight gain, arthralgia, contraindicated in liver dysfunction. Naticlinide can cause dizziness, nausea, flu-like syndrome, and joint pains. Hypoglycemia and weight gain are both the symptoms of sulfonylureas as well as non-sulfonylureas. Anyways, non-sulfonylureas are not the ones which we are preferring these days. Coming to the biguanides, the most commonly used drug, metformin, belongs to the group of biguanides. It is the only drug of this class presently available because fenformin is banned. Only biguanide which we use metformin. No other fenformin are not available or not used. It does not cause hypoglycemia and it is weight neutral and it is inexpensive. And the mechanism of action is they increase glucose uptake and utilization in the skeletal muscle. So it means that they are not acting at the level of pancreatic cells. They are acting at the level of the cells or peripheral skeletal muscle. Whereas that sulfonylurea, they act near the pancreatic cells. Whereas this one near the skeletal muscle. They increase glucose uptake and utilization in the skeletal muscle, thereby reducing insulin resistance and reduce hepatic glucose production or gluconeogenesis. So one word to remember is they reduce insulin resistance, metformin. And the initial starting dose of metformin is 250 to 500 depending on your case and how the patient presents to you. 500 mg once or twice a day, and it can be increased to 1000 mg BD, like almost up to 2 grams. And the adverse effects are dose-related gastrointestinal disturbances, which is common with any other drug. And next one is lactic acidosis, and it is rare but potentially has a fatal toxic effect. And the long-term use may interfere with the absorption of vitamin B12. So whenever a patient with long-standing diabetes on metformin, always prescribe the B-complex tablets. Okay, and fenformin is banned because of lactic acidosis, which is very potential toxic effect of that particular drug. So lactic acidosis in case of metformin is rare, but if it is present, it can be toxic. So see, in case if the patient is in sepsis or any other condition and where the lactic acidosis can be there, it can be avoided. So contraindications are renal failure, stage 4 and 5, hepatic disease, and heart failure or shock or acidosis. That is about the biguanides. Coming to the next group of drugs, they are thiazolidinediones. They are rosiglitazone and pioglitazone. And the mechanism of action is they bind to the nuclear receptor called peroxisome proliferator activated receptor gamma, which is complex with that of a retinoid X. Retinoid X receptor. So the PPAR gamma receptor, it is found in highest levels in the adipocytes but is expressed at a lower levels in other tissues. They promote adipocyte differentiation and reduce hepatic fat accumulation. Okay, so there are this PPAR receptors are of 3 types: alpha, beta, gamma, and the ones which we are talking about in the diabetes chapter or when we are talking about thiazolidinediones are PPAR gamma. These, along with that of retinoid receptors, are usually present, and their concentration is more in adipocyte. Why am I stressing? Because there is other type which is used in as an hypolipidemic agent, PPAR. So it is a thing that you have to remember. PPAR gamma receptor in the adipocytes, they promote adipocyte differentiation and reduced hepatic fat accumulation. And the adverse effects are weight gain, fluid retention, gastrointestinal disturbances, fractures, and increased cardiovascular risk. And contraindications are heart failure and liver failure. Coming to the next group of drugs, that is alpha-glucosidase inhibitors. Um, and to mention, there was rosiglitazone and pioglitazone are used. There was the other glitazones are banned because they had the serious adverse effects of bladder cancer, which were given the black box warning. Now, the presently used thiazolidinediones are rosiglitazone and pioglitazone. Next group of drug is alpha-glucosidase inhibitors. First of all, what is alpha-glucosidase? It is an enzyme present in the intestinal brush border cells, which is helping in the breakdown of complex carbohydrates into simple sugars, and the simple sugars are utilized by the body usually, or like absorbed by the body. Now, if at all we are blocking the alpha glucosidase, inhibitors is nothing but you are blocking that alpha glucosidase. Whenever you are blocking that enzyme, the complex carbohydrates are not being broken down into the simpler ones. Whenever they are not broken into the simpler ones, absorption into our body is delayed, or like not absorbed in adequately, is not absorbed adequately. Whenever the absorption is decreased, glucose levels in our body decreases. That is the main mechanism of alpha glucosidase inhibitors. But the thing is, like when it is not absorbed, the sugars are not absorbed in our body because of alpha glucosidase deficiency. Because of our induced inhibitors causing the deficiency, the complex sugars are present. Whenever the complex sugars are present inside the body, or like inside the intestine, and which are not absorbed, they cause other gastrointestinal side effects. Because of that, the patient can present with flatulence, loose stools or diarrhea, and abdominal pain and bloating. Okay, so that is the reason for the side effects of alpha glucosidase inhibitor. Coming to the types of alpha glucosidase inhibitors, they are acarbose and miglytol. Acarbose is something which is commonly used comparatively, an inhibitor of intestinal alpha glucosidase, and it is used in type 2 diabetes. Mechanism of action is it delays carbohydrates absorption, reducing the postprandial increase in blood glucose levels. Adverse effects, as I told you, and the contraindications are renal and liver diseases. Coming to the next group of drug, that is GLP-1 agonist. First of all, as we talked about what alpha glucosidase is, GLP-1 is nothing but it is also an enzyme. What it does is it is an endogenous enzyme which is secreted whenever we have the meal, and what it does is uh, uh, it reduces the uh, transit time. It reduces the transit time of the GIT, and thereby it causes satiety. When the satiety is there, the patient doesn't feel like taking more diet. Because of that, the sugar levels are not increased. The mechanism goes that way. Examples are exenatide, liraglutide, and exenatide LAR. Mechanism of action is it prolongs the endogenous GLP-1 action. It does not cause hypoglycemia. See, how is it like prolonging the endogenous GLP-1 action? It has something similar to that of the exogenous and endogenous, both are same action. What they does is they prevent the transit time or decreases transit time. So more amount of time the food is inside the stomach. When the food is more time in the stomach, what is happening? Patient feels like his stomach is full. when it is full, he won't take the excess meal. When he is not taking the excess meal, the sugar levels are not increasing that much. Because of that, there is no chance of hypoglycemia, because you are not giving insulin or you are not decreasing the sugars. You are only reducing the transit so that the increase in sugar levels are decreased. Okay. The initial dose of hexanatide is 5 micrograms and uptitratable up to 10 micrograms twice daily, and it can be given 60 minutes prior to the meals, which can help in decreasing the transit. Initial dose of liraglutide is 0.6 milligrams, uptitratable to 1.2 and 1.8 milligrams once daily without any relation to meals. And the dosage of hexanatide LAR is 2 mg once a week without relation to meals. So these are the three forms: hexanatide, liraglutide, and hexanatide LAR. The one important question that sometimes they keep asking you, this hexanatide, these group of drugs, they are derived from which animal or from where? It is taken from the gila. Any answers? I don't want to say, I want you to give me the answer. Where is it? I think you know it from your pharmacology. Where is it derived from? Hexanatide, liraglutide. Just recollect and give me the answer. Okay. GLP-1 and GIP are the two major incretins. Okay, so now as I talked about GLP-1 in the previous slide, there is one more thing called as GIP. What is this? First of all, what are they? They are incretins. What are incretins? Incretins is nothing but something which helps the insulin in its action. That is a like essence, or like the key one word thing which you can talk about. And coming to in detail about GLP-1, it is secreted by the L cells in the distal gut, that is ileum and colon, and it stimulates glucose-dependent insulin release. And it suppresses hepatic glucose output by inhibiting glucagon secretion in a glucose-dependent manner. It enhances beta cell proliferation and survival in animal models and isolated human islets. Okay, that is the action of GLP. So finally, whatever it is doing, what is it doing? It is decreasing the transit and is helping in the insulin release. So it is having an insulinotropic effect. So it is helping in the control of blood sugar levels. So we are using GLP-1 agonist. And coming to GIP, GIP is glucose dependent insulinotropic polypeptide. It is secreted by the K cells in the proximal gut or duodenum, and it stimulates glucose-dependent insulin release. It enhances beta cell proliferation and survival in islet cell lines. Now coming to the next group of drugs, they are DPP-4 inhibitors. DPP-4 inhibitors are again of the same action as that of previously we told before. First of all, DPP-4 are nothing but they are DPP-4 is an enzyme which is involved in breakdown of GLP. So whenever the GLP is present, DPP-4 enzyme is coming and breaking it. So now what we are doing is we are inhibiting the DPP-4 enzyme. Whenever the enzyme is inhibited, so it is not available to go and break down the GLP. So whenever it is not breaking down, GLP levels in our body increases. So the DPP-4 action is not direct, it is an indirect action. What all it is doing is inhibiting the breakdown of GLP. So GLP-1 is increasing. Whenever GLP-1 is increasing, what happens? The satiety is increasing, patient is not taking, and it also has an insulinotropic effect. These two are the mechanism of GLP. So DPP-4 inhibitors also contribute to the same. So their mechanism is also the same, just that it is preventing the breakdown. Examples of DPP-4 inhibitors are saxagliptin, sitagliptin, vildagliptin, and tenagliptin. And the mechanism of action is prolonged endogenous GLP-1 action. It does not cause hypoglycemia. And the contraindication is reduced dose with liver diseases. Even in renal failure, the drug which you can give is DPP4 inhibitor. So that is the reason we usually prefer sitagliptin or gliptins, any kind of gliptin in case of renal failure, because most of the patient parallelly present with birth. Coming to the next slide, incretins modulate insulin and glucagon to decrease blood glucose during hyperglycemia. What is the mechanism? See, whenever the food is taken inside the GIT, what is happening? The food is digested and sugar levels will be gradually increasing in our body. So parallelly, what is happening whenever the food enters the intestine, and it also releases along with the food digestion which is happening, because of the food present in the intestine, it releases the active incretins. What are the incretins? As we talked before, GLP-1 and GIP. These two are activated. So whenever these two are activated, what they do is, one effect is on the GIT, where they decrease the transit time, and the other action is on pancreas, where they are stimulating the beta cells. And what happens? It is a glucose dependent increased insulin from the beta cells. GIP-1 and GIP both increases or stimulate the beta cells, and they increase the insulin levels. Because of that, there is increased peripheral glucose uptake. Okay, and also it decreases hepatic glucose production, beta cells. So overall, both of them contribute to decreased blood glucose in fasting and postprandial states. Okay, and also glucose, it also stimulates alpha cells. What are they doing? It is a glucose dependent decreased glucagon from the alpha cells, or GLP-1. So there's a parallel thing. What the DP4 is doing is, they are breaking down GLP and GIP into inactive forms of GLP-1 and GIP. So DP4 enzyme is breaking here, or not, or preventing like GIP-1 action. So if you want to treat diabetes or hyperglycemic state, either give GLP-1 agonist, GIP agonist, both similar action we want for reducing sugar. Whereas for DPP4 inhibitor unit or antagonist unit, because you don't want this enzyme in case of hyperglycemia. Coming to next group of drug, that is SGLT2 inhibitors. SGLT2 inhibitors examples are canagliflozin, dapagliflozin, empagliflozin. These are the gliflozins available. So what is the mechanism of action of SGLT2 inhibitors? This is the nephron, where you are seeing the proximal tubule and the loop of Henle and the distal tubule, etc. In the proximal tubule, what is happening is, most of the substances are absorbed in the proximal tubule only. Proximal convoluted tubule, proximal tubule. Then comes loop of Henle. This is the part where the major amount of absorption of elements or ions are taking place inside our body. Similarly, glucose is also absorbed most from this part of the nephron. In the initial stages, you have SGLT is nothing but sodium glucose transporters. These sodium glucose transporters are present in the proximal tubule. They are of two types, SGLT2 and SGLT1. SGLT2 is present in the initial maximum part of the proximal tubule. It absorbs more amount of glucose, like maximum amount of glucose is absorbed through SGLT2. Next, the terminal portion of the proximal tubule, which has SGLT1. SGLT1 also absorbs sodium and glucose, but with more affinity. but it has, as most amount is absorbed by the SGLT2, SGLT1 has a minimal amount of sodium and sodium and glucose absorbed, but it has more affinity. So whatever the leftover sodium and glucose is absorbed with the help of SGLT1. So SGLT2 is covering the maximum part. So in case of diabetes or sugar, when the sugars are high, when you want to prevent the absorption of sugars, you want to block the SGLT2. So whenever SGLT2 is blocked, the glucose and sodium uptake are prevented. So if at all this is a cell, if you see this is an SGLT2 transporter, sodium and glucose are taken up parallelly, and with the help of GLUT2, glucose is taken into the bloodstream. Sodium with sodium potassium ATPase, it is circulating in the blood. If this is a nephron with a proximal tubule and this is a urine, sodium and glucose which are present in the urine are absorbed in the way which we talked before. Reabsorption is taking place. Now, when you give SGLT2 inhibitor, this pump is not working. So what is happening? Sodium and glucose both are not absorbed into the bloodstream. When they are not absorbed, in the urine, the concentration of glucose and sodium is increasing. So glucose, whenever it is decreased in the body, as it is not absorbed and excreted in the urine, it means that the glucose levels in the body is decreasing. So whenever the glucose is decreasing, that is good for diabetic patients. So that is how it can help in treatment. And also parallelly, if you see, sodium is also not absorbed. When sodium is not absorbed, what is the thing? Hypertension can be prevented. So this SGLT2 inhibitors can help in reducing the hypertension to an extent of 6 to 10 mmHg or like 6 to 8 mmHg. Not significant, but you can use this for the patients who have hypertension and diabetes. Coming to the disadvantages, they require renal adjustment because it is something to deal with the kidney nephron and all the mechanism. So it requires renal adjustment if at all you are going for it in case of renal failure, and it has an adverse effects like more amount of adverse effects which we'll talk later, and it has a very high cost. And the adverse effects are endocrine and metabolically. If you have to say what adverse effects are, hyperglycemia, hyperkalemia, hypermagnesemia, and increased cholesterol and dehydration can occur as you're blocking the nephron, sodium, potassium, sodium and glucose channel. And cardiovascular, it can present with hypotension because sodium is not absorbed. There can be orthostatic hypertension and syncope can occur. And then come to the renal or genitourinary adverse effects. There can be increased micturition frequency, UTI can occur, mycosis or yeast infection, and renal impairment can be there. And other effects are pancreatitis and angioedema can occur. And the contraindications are avoid or discontinue if creatinine clearance is less than 45 ml per minute, and ensure the patient is euvolemic. Coming to the other group of drugs, PPAR, dual agonists, alpha and gamma. These are termed as glitazars. Several dual PPAR alpha and gamma agonists have been developed. What it does is PPAR alpha and gamma, it has alpha has a fibrate-like effect. What it does is fatty acid oxidation, thereby decreasing triglycerides and increasing HDL, which is lipid lowering action. And gamma, more of it has the thiazolidinediones-like action, like adipogenesis, lipogenesis, and increase glucose uptake, and glucose lowering effect can be present. So this is the dual action of both. Saroglitazar, the first glitazar to be approved in India is in 2013, and indications are diabetic dyslipidemia or hypertriglyceridemia in type 2 diabetics, which is not controlled by statins alone. And this is the last slide almost, where how you have to start the treatment or how do you Usually initial, up to now what we discussed about all the drugs. Now this one is something where you're talking about how you titrate the doses and all. First, a patient with a high BMI, he comes to you with the initial or recent onset diabetes or increased sugar levels. You label him diabetic because he is having high sugar levels and HbA1c is more than the target. So you start him on. First, what you have to advise is you have to categorize whether he is under high risk or low risk, or he is not at risk. And you have to see if at all he is having any side effects of that of metformin. If he doesn't have any side effects and he is at the high risk or low risk or whatever the risk, first advise him lifestyle modifications. What are the lifestyle modifications? Dietary habits and as well as daily exercise. These two are the initial ones which can contribute to a significant level of glucose control. And the medication which you can start is metformin. This is the thing. And you have to ask the patient to return back in 3 months. Whenever the patient comes to you in 3 months, again check for the HbA1c and the sugar levels. If they are under control, continue the same. If they are not controlled, then you need to ask the patient to increase the dose. How do you want to increase? Either you want to give metformin plus sulfonylurea or metformin plus rest of the drugs. And the patient having high risk or moderate risk, and you think like hypoglycemic and see here's the side effects of sulfonylurea. If both are going hand in hand, like you think if they are going to complement, then put the thing, otherwise go for the next drug. Sulfonylurea can cause weight gain, and if at all the patient is already obese, think about it and try not to give sulfonylurea and go for the next drug. And thiazolidinediones, here the side effects are edema, heart failure, which was there. So you don't want to, and also weight gain. So you don't want to put the patient on thiazolidinediones. Then go for DPP-4. Here it is weight neutral, or it is not something to deal with weight. So and this patient's DPP-4 it doesn't have any higher risk also. So if you want to start the patient on DPP-4, you can go with the DPP-4 without any complications, because that is somewhere a safe drug. But the amount of glucose reduction with DPP-4 is very less. So if you want to start him, you start him on DPP-4, and if you're still not achieving the control, then you can add up sulfonylureas. Or SGLT2 inhibitors can be added. SGLT2 also you check for the side effects, like if at all there is any urinary tract infection, dehydration is there, don't give it. If not, you can try giving SGLT2 inhibitors. And then coming to the next group of drug, or GLP-1 receptor agonists. This is also of very high cost and is not preferred usually. If you want to go with the DPP-4 or SGLT2 apart from sulfonylurea. And then coming to the next class is insulin. Depending on the how much levels of HbA1c or FBS and PPBS are, then according to that you need to put the patient on insulin. It has highest risk of weight gain, and hypoglycemic episodes are very high. So if you want to treat the patient as an inpatient and control his glucose levels, insulin is the best choice. But usually whenever the patient is coming only in an OP, they are not willing to take insulin. That is with insulins. And then coming to the, up to now we talked about the dual therapy. After giving whatever these drugs, you ask the patient to come back in 3 months. After 3 months, again check for FBS, PPS, and HbA1c. If your sugars are under control, continue the same. If they are not under control, you need to step up the treatment. You need to add one more drug. What is that one more drug? If at all, in the first case, if you have metformin and sulfonylurea, you try to add any of the below agents like thiazolidine, DPP-4, SGLT2, GLP, and etc. If at all the patient is on metformin, thiazolidinediones, try to add sulfonylurea, DPP-4, SGLT2, insulin, GLP according to his glycemic status. Or if not, then go for if at all patient is on metformin DPP4, then go with sulfonylurea, thiazolidine, and SGLT2 inhibitor and insulin. If at all patient is on metformin and SGLT2 inhibitor, then you go for the rest of the drugs. This is how you alter the treatments. If at all the patient is on insulin itself, then try to add some sensitizer. What are the sensitizers? You can use sulfonylurea or thiazolidine, DPP4, SGLT2, GLP. The thing, sulfonylurea is already insulin you are giving. Patient insulin might be secreted depending on his insulin resistance. If you give sulfonylurea more amount of insulin, it is also helping in insulin release. So there are more chances for hypoglycemia. That is why they didn't put here like metformin, insulin plus sulfonylurea. Okay. So in spite of this, the control is not achieved in 3 months period or so, then you go with the combination injectable therapy, that is basal insulin plus mealtime insulin or GLP-1 receptor agonist. Okay, basal insulin, and that is like something we talk about in the insulin chapter next time. Baseline insulin plus intermittent insulin, which we give according to the mealtime. That is the combination injectable therapy. Okay. Um, so that is with the OHS topic. Do you have any doubts, or do you want to ask anything? If you are not having any doubts, I'll meet you in the next class. You can put your attendance in the chat box.